All right, it's noon on the East Coast. Hey, everybody, this is Brandon Garrett with the National Minority Quality Forum. Thank you for joining us this Friday afternoon. Well, afternoon if you're on the East Coast, or morning wherever else in the U.S. We thank you for joining today's panel on conserving life and kidney care, rethinking ESRD payment bundle, the ESRD payment bundle, excuse me. This webinar to be led by Kelelaye Emiru. He is our Vice President for our Center for Professional and Strategic Alliances. Kelelaye has been with us for the last, what, 3 years now, Kelelaye?
That's going on 3 years.
Coming 3 years, and he comes from the pharma world and he came to the nonprofit health world. So we really appreciate him for lending his expertise to not only this topic, but to all the work he's done. He and Michael, the dynamic duo, do for NMQF. Before we get into the meat and potatoes of the conversation, I just want to get some housekeeping things. One, if you have a question that you'd like the panelists to answer throughout, please put it in the Q&A box that's listed below. And then two, if you have a comment and just want to sort of keep the conversation going or maybe point people to a particular study that was mentioned or have any other random musings, please use the comment box and we will get to the questions throughout the program. But without further ado, there are people that have far more expertise in this area than I do, so I'm gonna turn it over to Kelly.
Thank you, Brandon. I appreciate it. Thank you, Ashley, and everyone who's been able to help get this webinar together. Hi, everyone, and welcome to all of you who are able to join us today. My name, as Brandon said, is Kelelaye Emiru. I serve as the Vice President for the Center for Professional and Strategic Alliances here with National Minority Quality Forum. And today's webinar is actually being hosted by Nephrologists for Equitable Kidney Care, or NEC, which is an alliance that was founded under NMQF about a year ago. It was about that time we came together publicly for the first time to shine the light on what was happening in the kidney space as it relates to the needs and some harmful policy shifts that we were noticing. And since then, ESRD bundle has actually expanded to include oral-only drugs, particularly phosphate binders, that was effective January 1st, 2025. So today we're here to revisit that change and ask what is the real impact on patients and clinicians, and most importantly, what can be done and how can CMS realign these reimbursement policies so that they reflect biology and prioritize outcomes for patients that we know are disproportionately being impacted, and how can we ensure optimal kidney care for all. So we want this conversation obviously centered on patients because at the end of any data or any policy that you see is a real patient. And our panel represents clinicians, patients, patient advocates, as well as industry leaders and policymakers. So they bring this essential perspectives on how to fix what's working and what's not working, and how to conserve life so that we can have better kidney care for everyone. So I'm honored to introduce five phenomenal guests. Let me start with Dr. Ruby Harford. She's president and CEO of Atlantis Healthcare Group, and she represents the healthcare dialysis perspective. We also have Crystal King, who is a friend and founder of executive director, the Kidney Champion Foundation. She's also a kidney patient. And we'll hear from Dr. Laura Williams as well, who's the Chief Medical Officer of Ardelyx, representing the industry's perspective. Edward Hickey the third is president of the American Association of Kidney Patients, who is representing the nonprofit alliance focused on kidney patients. We're fortunate to have that collaboration with the AAKP. And then we have Dr. Cameron Blackmore. So Dr. Blackmore is a health policy advisor, Office of Congresswoman Terry Sewell. She'll be giving us her perspective from a policy standpoint. So welcome to all my panelists. I think this group really represents the entire ecosystem when we talk about kidney care. And I want to actually begin by grounding us in terms of where we are today and take a moment maybe to explain what we mean by ESRD bundle. I know there may be folks on this call who may not be sure exactly what that entails and what that means for today's conversation, because I think this would be central to what we discuss. So the end-stage renal disease prospective payment system, often called or referred to ESRD bundle, is how Medicare or how CMS pays for dialysis centers for treating patients with kidney failure. So instead of paying separately for each drug, lab test, or some sort of services, Medicare combines or essentially bundles all of these costs into a single payment per treatment. So initially, the promise was efficiency, but we know the lived experiences and what we're hearing from patients and healthcare providers tells a different story. So, with access challenges and care disruptions, and inequities are now starting to weigh out and weigh heaviest on the most vulnerable that are disproportionately being impacted. So that's why understanding the bundle is important. It's not just about the economics. I know we talked about in the past, and NMQF has been loud about how do we focus policy? How do we focus payments? How do we focus technology and the shift that we're seeing in healthcare back to the science and what patients' bodies actually need, the biology to stay alive. So, with that foundation, let's turn to the clinical and dialysis center perspective. Dr. Williams, I'm going to start with you. How has adding this phosphate lowering therapies to the bundle impact patients' outcomes when we talk about outcomes?
Yeah, thanks, Kelelaye. I think at the first and foremost, I'm actually now the chief patient officer at Ardelyx. I want to just, set the stage here about why serum phosphorus is so important, right? So, when the kidneys fail, there are a number of different, biochemical blood values that go awry. And the most important one in terms of impacting mortality and morbidity is actually serum phosphorus. And so when the kidneys fail, you're no longer able to excrete, that excess phosphorus in the urine. And so you get this condition called hyperphosphatemia. And these phosphate lowering therapies were approved to actually help manage, to bring down those serum phosphorus levels. The reason that's so important is because there's a lot of retrospective data out there that says elevated serum phosphorus actually portends to poor outcomes in terms of morbidity and mortality. So increased hospitalizations, increased risk of death, bone disorders, calciphylaxis, because you get calcium deposits in the tissues, vascular calcification because you get calcium plaques in the blood vessels. All of those things are really important, and that is why we have guidelines that say we should try to do everything we can to keep serum phosphorus at a normal level. And so, there are three things really that you can do. One is diet, one is dialysis, and the other one is actual medications, these phosphate lowering therapies. And unfortunately, diet and dialysis alone usually are not successful in terms of getting people to where they need to be in terms of their serum phosphorus levels. So these phosphate lowering therapies are really important. And as I said, there's a lot of retrospective data that tie elevated phosphorus to these bad outcomes. And so, when you ask the question about how has adding these phosphate lowering therapies to the bundle system, how has it affected patient outcomes? Well, we're collecting the data now, but I think one already surmises that again, when we look at even just phosphate binders, right? So when I'm talking about phosphate lowering therapies, there are phosphate binders, there's phosphate absorption inhibitors. But when you look at the data, anywhere from 27 to 70% of patients, despite being on phosphate binders, actually are not able to control their phosphorus levels. And so what is required here is the utilization of all the available therapies to actually get people to where they need to be. And what we have seen in the past when other drugs like calcimimetics have been added to the bundle payment system is that actually utilization, once that initial period of evaluating how these drugs are used, once that initial period goes away, well, actually utilization of some of the more innovative therapies and perhaps some of the more effective therapies actually goes down significantly. And so when you think about what the impact, right, of putting now these phosphate lowering therapies into the bundle is, one would surmise that the outcomes will get worse. And so what we need to do is, prospectively collect that data, look at whether or not there's increased hospitalizations, which we think there will be. Again, also, dialysis was meant to be a bridge to transplant, and the fact that serum phosphorus is one of those things that we often look at when we think about a patient being transplant ready. Not an absolute criteria, but certainly something that is looked at. We also know that, not being controlled from a serum phosphorus level could actually impact, one's ability to get on the transplant list. So there are a number of potential patient outcomes that I think should concern us all, because this issue of hyperphosphatemia is actually something that happens in almost 80% of patients who are on maintenance dialysis, and it carries sort of the highest attributable risk of mortality and morbidity.
Thank you. I mean, this sounds like there's a lot of outcomes it impacts. My second question would have been, how can the industry show the value beyond cost? But it seems like you've touched on the survival, the hospitalization, certainly morbidity and mortality. Is there ways to tie this value to survival rate? You mentioned there's also the importance of uh, transplant, and then how do you tie that in terms of the value that can actually be equated to products like phosphate lowering therapies?
Yeah, so the US renal dialysis system actually collects all of that data. And so what we can do is actually look at the impact of increasing serum phosphorus in these patients. So we can actually look at how many patients are actually being controlled now that these drugs are in the bundle versus before, right? When access was not so limited. There was a recent survey by AAKP, that was actually done this year, that actually shows that 38% of patients, right, reported issues or difficulty actually accessing their phosphate lowering therapy after they were put into the bundle. And 70% of healthcare providers actually noted difficulty in prescribing the right medications for patients. And so what you're seeing here is um, the removal of individualized care, the removal of shared patient HCP decision making, and the limitations around access to all of the available therapies. I mean, if we did this sort of thing back in the day with HIV, we never would have gotten it to a chronically manageable disease. If we only had AZT versus all of the other therapies that then were added to be able to actually get people in a better place, it would be antiquated. And why would we not do this for dialysis patients for the issues that they face? It's the same thing with any complex medical condition. Let's take diabetes. If we only had metformin and didn't have all of these other drugs, we couldn't get people to where we needed them to be from a glucose level standpoint, from an A1C standpoint. The same is true for hypertension. The same is true for oncology. I mean, I don't know any therapeutic area where we rely on, sort of one form of therapy. We open it up, we individualize it to make sure that patients get the right therapy at the right time for their individual situation.
Thank you so much, Dr. Williams. I think the stifling of innovation and having the option for patients to get targeted therapy is a huge component of this. Dr. Hartford, let me bring you into this conversation. From a dialysis perspective, what are some of the challenges specifically independent dialysis centers are facing under this bundle?
Thank you for asking. Dr. Williams, well-made comments, because many of your comments go right into the discussion that I'm going to bring up. And that is since the inclusion of the oral drugs, the complexity, the administrative burden that has been brought upon to these facilities is huge. I don't believe that the community or CMS really saw what was going to happen, but I can tell you from firsthand, not just within our organization, but working with other organizations, having to work with the state pharmacy law, making sure that we are compliant with the dispensing, the storing, and also the collections and billing, and getting all the patient data forms that are required when you are working with prescriptive drugs. As Dr. Williams mentioned, when the dialysis programs came on board, they were meant to be a bridge to get into transplant. It was never meant, and I believe very strongly that policy was never meant that dialysis units would at some date serve to become internal pharmacy groups coming in to be able to prescribe and work with these prescriptive drugs. But the inclusion of the PLT has required dialysis units not only to expand what the administrative burden is right now, but we have to be able to look at, should we go and get our own pharmacy license to be able to save cost, which in some cases it has been advised to other programs to consider getting at their own pharmacy license. Should we be able to go ahead and now look at more how we contract with these other distributors, other pharmacies, because we as independent facilities, many do not have this integrated process, unlike many of the large organizations who are going to have a much easier transition into the inclusion of the oral drugs. But I would also take it a step further. Many of the small independent organizations are located in very rural areas, underserved urban areas, and these areas have much sicker populations, have larger communities that have a more higher impoverished levels. So when you look at how the impact with these independent facilities that are in these rural areas and how they're having to work with the inclusion of the drugs, they're being forced to look at the finance side of this, the economics of it. And what I mean by that is trying to negotiate great numbers to be able to provide these drugs, looking at generics versus brand. As Dr. Williams said, not being able to use maybe the more therapeutic, more effective, more innovative drugs that could be better for the patients. But because of the inclusion of the drugs and the limited funding, even with the TDAPA, it still has a huge impact on the complexity of the administrating this program, because we, as independent facilities who don't have a pharmacy license, who are not officially contracted with pharmacies, we have to go seek out contracting with the distributor and seek out another contracting with pharmacies for the pharmacy to be able to work with facilities to be able to dispense the drugs. And then within even the dispensing of the drugs, there's a whole entire internal layer that facilities have to adhere to for compliance. For example, getting the patients the drugs, we have to have all the nurses sign off that these patients receive the drugs. We have to get these signatures, documentation all back to the pharmacist so that they're compliant. And then we have to look at also how we're storing the drugs, and are looking at purchasing and inventory. Are we maintaining a safe warehouse and supply storage so that we don't run out of these drugs, so that we are able to provide to these patients in an emergency situation and non-emergency situation? So it's a very whole complex situation. And the sad part about it is that dialysis units who want to provide more for their patients through renal value-centric care, because of what we're doing now, many of the programs that had high level priority to be able to give more support to these patients, nutritional support, other programs that provide more compliance and education and training, those have to be put aside now, because the inclusion of the oral drugs has really been a huge financial hit and administrative burden to dialysis units. So for us, and what I see, not just in Atlantis, but working with our other colleagues, they are seeing the same thing. So again, looking at compliance and regulatory, a whole level of regulatory standards that we must include into the regular CMS and state licensing and certification. That itself adds a whole nother layer of complexity on the survey side.
Thank you, Dr. Harford. I know we've asked CMS to look at some real world evidence and the impact of this, but if CMS were to invite smaller dialysis centers, or even for your perspective, to redesign this model, what are some of the changes that you would recommend?
I would like to see more field visits by CMS and do like a more inclusive annual surveys that they gather more data. Exactly what Dr. Williams was saying. Look at the data that we're have, even just through USRDS, but go out into the field, go into these rural areas and actually speak to the patients, speak to the providers. And I would even go as far, even though the USRDS has data that is national and throughout the all mainland and all the US territories, but maybe we should do some adjustment factors. Look at what these rural areas, how they are managing the bundle. Look at the urban underserved areas and look what populations they are serving. I know CMS right now does a plethora of surveys and gathering data, but it's very fragmented. So to be able to get CMS to really do maybe some field visits, work with the patients, talk to the patients, because that's the real people you need to talk to are the patients. And you need to talk to the providers, the nephrologist. Dr. Williams, sorry, Dr. You mentioned your name again, but that relationship between the nephrologist and the patient is a very strong bond because patients see their dialysis units as that second family. That nephrologist is very key, that nurse is key. So when you begin to limit access, begin to limit the types of drugs, the innovative therapies, the more effective therapies, that really harms potentially the relationship they have with the nephrologist and their nurse because they're wondering, why can't we get it if we put into the system? We are beneficiaries. They don't understand that.
Right.
And so you have to do a lot of one-on-one. So I would highly recommend that CMS reevaluate how they're doing all their surveys. They do the RFIs, requests for information. But I think they need to take it a step more and not just do it for overall, but do a consolidated, comprehensive one. And then also looking at breaking it up and adjusting and factoring for what it's like to work with rural areas, underserved areas, and working with much sicker populations.
Thank you,
And
Dr. Harford. Go ahead.
yeah, and if I could just add to that, I mean, Dr. Harford is spot on. I think CMS already has an example of how this didn't work before, right? When we
Sure.
look at other drugs for patients who are on maintenance dialysis, namely the calcimimetics, their use spiked during TDAPA because there was an incentive. But once that period was over, we know that utilization actually went down dramatically. And so a lot of patients today can't actually get the more innovative therapies from a calcimimetic standpoint. And what did that do from an outcome standpoint? Well, the disease that you were, or the complication that you were trying to manage got worse and then led to more invasive procedures, namely surgeries. And so we've seen this before. And I think, again, it is more dire with hyperphosphatemia because more patients on maintenance dialysis are impacted by this. As I said, up to 80% of patients, and it carries a higher risk of mortality and morbidity. And so, I would suggest that before enacting these sorts of policies, let's collect the data and make sure we're not doing harm to patients and not, collect it on the fly after the fact, after the damage has been done. I think the other piece to understand too is that, again, when we talk about kidney failure, fourfold higher rate in Blacks, twofold higher rate in Hispanics. And so when you think about the outcomes, right, then who are the patients that are most impacted? These are a vulnerable patient population, and we really should be paying quite a bit of attention to that. And the last point I'll make is that these are oral only medications, these phosphate lowering therapies. They have to be given in association with a meal. They are not part of a renal dialysis service. There's no reason why the dialysis organization has to actually admit or administer, right, rather, those meds, because those meds are, as I said, taken in association with food. And typically, meals are not even allowed. at the dialysis center.
Correct.
And these drugs have to be taken several times a day. They don't live in the dialysis chair. They live at home. And just like they take their antihypertensives and their, diabetic medications at home, they should be taking these medications at home. They are not part of a renal dialysis service.
Thank you, Dr. Williams. I think that's you bring up some very interesting points in terms of how this has been seen in calcium mimetics and other prior classes in the past, and the impact that it has. And then patients that are at the end of these policies that are impacted the most. I think this is a good transition to hear from those who feel these policies most directly, including patients and patient advocates who's been a voice for patients. Crystal, let me come to you now. And can you tell us how kidney disease affected your daily life? I know there's so much medication, often thinking about nutrition. At one point, I'm sure dialysis was also part of that. So just tell us how this kidney disease impacts your daily life.
Yeah, so I was diagnosed with kidney disease as a pediatric. I was in middle school when I was diagnosed with kidney disease, and I went into kidney failure later in life at age 36. I was on dialysis. I did peritoneal dialysis, which is dialysis at home, and I did get a kidney transplant in 2020. But even though I've gotten the kidney transplant, I still live with the daily realities of kidney disease. I take multiple medications every day. Right before this call, I was actually sorting out all my pills. I like to sort them in 30-day increments. And I take a handful of pills in the morning and I take a handful of pills in the evening. I'm very careful with my diet. I try to stay very active. Like I recently started playing pickleball just so I could, be, healthier and in better shape. But I also carry with me everything I know about the dialysis journey because I live with that. And I walked alongside so many people who are still on dialysis. I have friends who are still on dialysis. And dialysis patients face enormous burdens. We have strict fluid limitations, rigid treatment schedules several times a week, and again, that overwhelming pill burden. Um, Policies like adding the phosphate lowering therapies into the ESRD bundle only make that burden heavier. It limits choice. It puts patients at risk of losing access to the medicines that work best for them. And like you guys mentioned, that trust with your doctor, with your nephrologist, when you're on dialysis, like that is your family. I was on dialysis 7 days a week, like every single day, because I did peritoneal dialysis. If you're going in clinic, you're there several days a week. Like those people who are in those chairs with you, the nurses, the nephrologists, they're like your family. Like I remember at one point I wanted my nephrologist to write me prescriptions for other things that were not related to kidney because I saw her so much and I felt like, well, surely you can help me with my acne as well or whatever other things. And she was just looking at me like, Crystal, you have to go see a dermatologist for this or your PCP for this, because we had such a great relationship and I relied on her for so much. But back to the dialysis patients, it's a very, very fragile and vulnerable population. And those policies, they just don't create inconvenience, but they create life or death barriers to care.
Thank you so much for sharing your story with us, Crystal, because this is what I mean by, behind these numbers and these policies, there are real patients. And many of us personally know someone like you, Crystal, who are impacted by kidney disease. And the data really reflects something as deeper and ongoing inequity that we see in kidney care. I know many people on this call probably have heard that according to the National Kidney Foundation, there's 37 million American adults with kidney disease, and that's 1 in 7. So who live with chronic kidney disease, and nearly 90% of them are unaware of it. So we're talking about ESRD, which is a sliver, but this impacts a large population who could someday be on dialysis and would need some
Mhm.
of these therapies. So, in trying to be solution oriented, if let me ask you, so if patients could speak directly to some of
Mhm.
these policymakers who have power to make changes, what are some of the changes that you would ask for that are important to patients like you?
I think it's important to put the patients first. This means protecting our choices, ensuring that we have access to the therapies that work best for each individual, and removing those barriers that make access to care so hard. No one's health outcome should be dependent on what's most convenient or cost effective for the system. Our care should be guided by biology, equity, compassion. Patients just want to be treated like people, not numbers in a payment model. And I think that's what, as patients, we should be asking for.
Could not agree more. Thank you, Crystal. Edward, let me come to you. I know the AAKP survey was mentioned by Dr. Williams, and that survey revealed many patients feel that the bundle doesn't really reflect their needs. So, what were some of the most important findings, and what would be a good takeaway from that survey?
So Dr. Williams hit exactly on where the survey came in, and obviously we knew that some change or something different was going to happen, and we wanted to poll our membership to see exactly what it was. They're the ones who are living the experience, and they would be able to tell us. And what you had 38% of the patients that said that they were having difficulty getting their oral phosphate lowering medication. And in the dialysis, there was questions about distribution. There were questions about access, and it just created a whole nightmare for them. And as Dr. Williams mentioned, it impacts your ability to stay on, to either get on the transplant list or stay on it, because as you're going in for your transplant, if your health deteriorates, you're going to fall off the list. And so there were impacts there. There's real fear when you're on the list about maintaining your health so that you don't drop off. And this introduced a whole other factor there. So there was an allusion earlier to the interference with the relationship between the patient and the doctor, and it really is a sacred relationship. You have your the most intimate details of your life are being shared with a person. There's an intervening government entity that is affecting your ability or your doctor's ability to make decisions that are best for you, and they're not driven by what's the best outcome for you, but other factors like costs that you haven't ascribed to. You didn't sign up for it. You wanted to be able to make those decisions with your doctor, and then we always advocate for that. And it's we have a program called Patient Voice, Patient Choice at AAKP, and we register voters. We get people out to express what their concerns are to their members. And 72% of the healthcare professionals reported that there were disruptions in their ability to prescribe the drugs or to actually get the treatment to the patient, and that's a concern as well. So it was all pretty damning.
Well, yeah, those numbers are alarming. In terms of the work that you all do at AAKP and the strategies that you've seen, what are some of the most effective ways to mobilize patients and advocates? So, and what lessons have you learned from this work? Just again, trying to be solution oriented and trying to get patients' voices and those that are impacted to actually get CMS and policymakers to listen.
Sure. Well, we need a million Crystal Kings, I think is what the answer is. The most effective uh, strategy is to get the patient voice in front of the decision maker and have them hear actual patients tell their stories. And I've been in rooms with senators, congressmen, and presidents and leading experts in the field, and the most compelling voice in the room is always the patient. Everyone listens to what the patient has to say because it's real. It's not abstract, it's not a study, it's not an observation, it's an actual experience. And that's what everyone is there for. Everyone's trying to find a solution to make things better. And we reach out to policymakers, but the patient voice is the most important voice in that room. And we have a number of channels. I mean, we use social media. We use basically anything you can think of. We're using, but it's Crystal's story, or people like Crystal who can tell their experience, which really makes a difference.
Well, thank you very much for that, Ed. Let's transition and see how now we've talked a lot about how this is impacting patients and providers. I want to look at how Washington is responding and what Washington can do. So before I say that, I know that CMS is recently put out requests for information in the commenting period, and we actually did from NEC put in a comment, and at the end of that, we saw that there was a total of 224 comments that were submitted. And of those 224, only 5 supported the changes, meaning the bundle that went into effect in January. So that shows the widespread concern across the community. And Cameron, I want to bring you into this conversation now and talk about how policymakers can interpret that and what opportunities exist for legislation that can better align from what we've heard for patients and advocacy and those that are actually being impacted by this.
Yeah, so now it's in CMS's hands. We did have a legislation last Congress that pushed to delay the implementation of these drugs into the bundle. The bill passed out of both Ways and Means and Energy and Commerce, and then towards the end of the year, for reasons beyond our control politically, there was not much movement in the healthcare space. So unfortunately, that brings us to this point. I do want to kind of reiterate that we do not have a current legislative strategy in the House to move forward on further delaying this implementation. It has gone into effect. We have nothing to pull it back at this moment, but I think that it is important for all of the coalitions, all of the groups within the coalition to work together. Last year, there was synergy between the providers, the dialysis centers, pharma, as well as patient advocates to delay this implementation. But I think now that CMS has chosen to move forward, we've kind of lost a little bit of that synergy because there are stakeholders that feel as though they have invested in addressing this change to CMS. And so they would like to move forward with keeping a status quo. And I'm pretty certain that those are the 5 people, the 5 letters that we're referring to now. So I think I agree with Edward. We just need to kind of bring the voices back to the table and see how we can work with committee staff, both in Ways and Means and Energy and Commerce, as well as CMS, to see, what our legislative path forward can be now that these drugs have been moved into the bundle. And I'm pretty sure I can speak for my boss, Congresswoman Terry Sewell, in saying that our office would be willing to work on any type of legislative vehicle we can to address this issue.
Thank you, Cameron. You touched on the importance of having the collective voice. With that, what role can clinicians and patient advocates play in making sure that policymakers keep kidney patients top of mind when designing these type of policies, or even to try and go back and fix some of these policies that need to be fixed?
Yeah, so I think Dr. Harford made a lot of good points in her statement that I believe have gotten lost in translation. Those smaller dialysis companies that are responsible for providing their patients with these drugs now, and how they've kind of gotten lost in the sauce when we're talking about the bigger companies who have, you know, an army of lobbyists that are, you know, also weighing in with CMS as well as members on the Hill. I think it's going to really come down to how, and I don't have the answer, so I'm going to pose the question. How can we move forward now to ensure that patient access is protected with the implementation of these drugs into the bundle? I know we've talked a lot about having a report or CMS doing field visits. I think all of those things are great because it puts the onus back on CMS to say, you know, look at the policy or the rule that you're moving forward with finalizing, and let's get some information to see how that is weighing on our healthcare system writ large. So I believe that keeping the pressure on our offices as well as on CMS to hold the light to their rule, like what is the impact this has had on patients? You know, is this preventing patients from moving forward with their transplant goals, with their transplant needs? You know, is this increasing hospitalization? I think any economic because I'll backtrack. The Kidney Patient Act, the bill that we had in Congress last year, did not have a score attached to it. So that meant in that current time, it was not going to add any money to the budget. It was really common sense legislation, and I hate that we weren't able to move forward with it. But if we're going to move forward to something that could potentially have a cost attached to it, we would like to know that. I think that that's the great way we can kind of push back on like the cost effectiveness argument. You know, if hospitalizations are going to increase, if patients are going to have barriers to their transplants, then this is not a cost effective solution, and we need to go back to the drawing table to see how we can protect access to these drugs.
Thank you so much, Dr. Blackmore. Dr. Williams, did you want to chime in?
No, I think Cameron had some excellent points. Really, again, everybody has. I mean, it is the core of the issue is the patient and looking at those patient outcomes and knowing that they're negatively impacted, but also then attaching, you know, sort of the economic rationale here. We know that, you know, some of the costs that you see in CMS don't reflect the downstream issues that happen when these patients then are negatively impacted by some of these outcomes. I mean, for example, in 2022, you know, Medicare fee-for-service spending per person was over 6 times higher for patients on dialysis at almost $300,000 than for transplant recipients at $45,000. And so we know that there are cost benefits, right, of making sure that patients are have the best potential outcomes. And again, I think one of the big ones really is, you know, can we show that, you know, controlling serum phosphorus or managing serum phosphorus actually helps patients become more transplant ready? Because we already know the 5 years, you know, survival rate for a transplant patient is 80%, and for somebody on maintenance dialysis, it's less than 50%. And so, in and of itself, right there, you know that there are economic benefits to doing the right thing. So we have to highlight those issues as much as we can. And you know, a number of us are collecting real world evidence data to actually be able to make those kinds of arguments.
I would add on to what Dr. Williams and Dr. Blackmore are talking about. You know, let me start off with first, we need to talk about what's going on with the patient. As Dr. Williams mentioned, look at the outcomes. But what we have to look at is, you know, when the cost effectiveness and the benefits of having these patients to have better therapy, access to these more effective, innovative drugs. How is it going to, by putting in a much better, stronger program with these PLTs, we need to avoid the hospitalizations. We need to avoid the urgent care visits. We need to avoid all the complicated measures that come in the management and care of someone with hyperphosphatemia. So I think that gathering the data, and not just gathering the data, looking at hospitalization, looking at urgent care visits, looking at premature death, we need to look at tying all the costs. And that means looking at not just the fee-for-service data, we need to look at all the data across the board. We need to look at Medicaid data, utilization claims. We need to look at the commercial side of it too, because eventually those patients that are commercial patients are eventually at some point going to cross over into the world of Medicaid, the world of Medicare, or the world of the dual population, right? So I think we need to look at it in its totality, look at the major framework and not adjust things out. Because as Dr. Williams has shared and everyone has shared, we're hearing from Crystal and Mr. Hickey, you know, we don't feel what's happening because we're not a dialysis patient, right? But if you go and talk to that dialysis patient and go live the life of that patient, I think Congress needs to look at, you know, when we have a meeting, I would highly recommend, because we found this to be very effective in doing our presentations in public meetings, to put a patient out there, doing it at Ways and Means Committee meeting, Dr. Blackmore, put a patient out there with a remote RO, dialysis, let them do the 4 hours and let them hear what's going on and what the interface is between a patient, the nephrologist, and the nurse while the Ways and Means Committee is going on, and the drugs we're having to give, the orientation, the education and training we have to give on the phosphate drugs, on the calcimimetics, on the ESA drugs. That needs to be seen in her, because it's one thing to read and look at numbers, but it's another thing to see a patient, a family suffering through this. And I'm looking at across the region. I'm looking again, I'm going back to my rural area, to my independent facilities, and looking at even all the organizations. But a picture is very impactful. Seeing the patient, hearing the patient speak, and seeing that sacred relationship. Crystal, you mentioned that, the sacred relationship. We see this all the time. You know, patients who lose their doctors maybe because of an insurance change. It's very heartbreaking. So I say that akin to losing access or choice to drugs. When you begin to eliminate choice, compliance begins to drop. Patients don't understand, the caregiver doesn't understand. So I think using the same old route of, yeah, let's look at the data, let's look at the economics. But I'm telling you, I feel very strongly, put the patient there, the patient face, how the patient, what the patient experiences. And now in this day of the baby boomers, what are the caregivers? What are they experiencing? Taking care of their loved ones on dialysis or trying to get through transplant. So I think we need to look at a bigger framework. Look at what NEC has put in, the NMQF is putting that framework of the physics of biology. But we need to put that in front of Congress, put not one, maybe two patients there. And they need to talk about it and let them see what it's like when these patients may experience post-fatigue. That's a real issue. So, you know, again, hammering on supporting, at the end of the day, we need to hear the voice of the patient, and the numbers count, you know, outcomes count, they're very important, but we need to look at it in its totality.
Yeah, and while, you know, we would love to have a 4-hour visit and kind of get into the life of the patient, but unfortunately, we have a lot of time constraints, a lot of different conditions that we work with across the gamut of, I've probably talked to every patient advocate group in Alabama. Don't underestimate the power of a 15-minute meeting or a letter to the staffer, just highlighting what that experience is like. Because I mean, you could ask Dr. Williams, me and her, we didn't meet for a long time. You know, it didn't take her long to convince me that the Kidney Patient Act was a piece of legislation that my office needed to lead on. So, you know, I always encourage patients, you know, you can definitely get your point across in 15 minutes. A lot of times, either the member already engaged on, like, in the healthcare world, and they'll be interested in it, or they won't, you know, but keep, you know, there are 535 offices up here. So there's a lot of opportunities for support.
And that's an important point. So, because we're in the days of technology advancing, you have AIs reading comments and letters and even emails that you send. I don't know how it's done in Congress, but Cameron, what's one piece of advice you'd give to this audience specifically about engaging policymakers and to have an impactful change that we desire to make?
Yes, I understand it's really tough to get a staffer or an office writ large's attention if you're already not engaged with the office. I would encourage everyone to look at your member of Congress. We have events in our district all the time. We always have a healthcare component at every event that we put on in the district. And oftentimes we even have full out healthcare events. Look at your congressional members, sign up for their newsletters. I think things may change a little bit with security concerns, but I think for the most part, if you can't travel to DC, because I know it's expensive, it's thousands of dollars, it's ridiculous. But if you can't come knock on a members of Congress door, every district has a district office. You can touch base with that district office, and oftentimes there's a great relationship between the DC staffer and the district staffer. You can use that district vehicle to get in touch with the staffer in your particular member's office. I think that's my biggest piece of advice. I know a lot of people don't really understand how to navigate this landscape, but it's doable. And you can mail letters. I get letters on my desk all the time. If I skim it and it's like interesting and someone is like telling me about their experience, I'm more than likely in my free time to pause and read about those things. And that's across the board. That's my biggest piece of advice.
Thank you.
Thank you so much. I know we've got just a few more minutes left, and in that time, I want to make sure if there are any questions from the audience, Michael, I don't know if you want to read them off. I know there was a lot in the comment sections.
Sure. The first one I'll start with, and I'll also add it into the chat momentarily, is what is the impact on veterans on dialysis who traditionally receive dialysis in community centers versus a VA dialysis clinic? That is the first question, if anyone wants to tackle that one.
Yeah, I would say the impact is similar across the
Mhm.
board, right? I mean, again, at the end of the day, bundling these phosphate lowering therapies will impact a patient wherever they get their care. I mean, we also saw, a similar issue, for example, in nursing homes, where in addition to the survey that we talked about from AAKP, we have found that there have been significant disruption, if you will, in access to phosphate lowering therapies in nursing homes. And I think, from a veteran standpoint, there were probably already some restrictions in terms of, the available therapies. And I think this bundling of PLTs probably even impacts that more.
I would agree with Dr. Williams, and in our organization, we manage a number of veterans in our program, and it's very similar. If anything, it's exactly the same for the vets to be managed in an outpatient community care center program.
Thank you both. Michael, I think there was
there's a few more. The next one is will TDAPA be extended to 3 years, and will post TDAPA add-on payment be made permanent?
Yeah, I don't know who wants to jump in here, but obviously that is just like the inclusion of phosphate lowering therapies on January 1st, 2025 was a CMS decision. So will this be, right? I mean, I think it's hard for any of us on this panel to predict, what CMS will do as it relates to TDAPA, but it'll be something that we keep our eyes on and figure out if there are ways, again, that we can work with CMS to right this wrong.
Yeah, there is 2 more questions if anyone wants to tackle it all, and I'll say the next one. And it might be kind of the same thing that we just talked about, but It's will billing for actual uses prevent a windfall to clinics who donate and adopt innovative therapies? And I'll also put that in the chat. I also see a question in the comments here, but if anyone wants to tackle my question first, if not, we can move on to the next one.
Yeah, that one is not very clear in
Mm.
terms of what it's referring to. So maybe we'll ask them to, describe the question, elaborate a little more, and then go to the next one.
Yeah, there's one in the chat. It says, is there any opportunity for collaboration between this organization, so NEC and NMQF and others, and NKF, so the National Kidney Foundation and other organizations to work on priorities discussed today for CMS?
Yeah, I think there's always that opportunity. I mean, and I know from an industry perspective, we work closely with NKF, we work with AKF, we work at AAKP, we work with all of the patient advocacy groups. Obviously, we work with NMQF, with NEC. I mean, again, this is something that we have to tackle in a collaborative way. Again, the message is clear to me. What is best for the patient? We have to start there and end there, right? I mean, at the end of the day, what is best for the patient? It might not, I mean, the least costly alternative is not often the best alternative for the patient. And that's the lens that we should be looking at this through, right? At the end, it's the patient that counts.
I would even recommend reaching out in the initial collaboration. As Dr. Williams mentioned, we collaborate with everyone, but reaching out to to Kelelaye and with the NEC program and NMQF, that's an excellent start because they are already navigating nationally through all these programs, and they would be definitely able to help to focus and help you where you can help to collaborate with the organization.
Yeah, and I would add, I always, and I tell lobbyists this often, I always encourage collaboration. It makes it easier for us as staffers on the Hill. And I would imagine, even within the administration, if you have a significant number of organizations on the same page about a policy. I know sometimes you can't always 100% agree with everything that's being put forward, but having that showing definitely helps us like vet an agenda and then decide how involved we want to be. If there's like a snag in the collaboration, it kind of creates like a more of a time delay because then we have to meet with this group and meet with that group and kind of see what the dissension is and then present that to our members and all of these things. So I always encourage collaboration. If there can be a compromise reached before you even get to the Hill, that always helps because it keeps us staffers kind of focused and just focusing in on getting the strategy through the House and the Senate.
Thank you. I will say from our perspective, we're very open to collaboration. We've done so with multiple organizations that are focused on kidney. That's the reason why we have AAKP here today. We've written letters and have had other organizations join in on this particular topic, including ASN, American Society for Clinical Pharmacists, and others. So I think this is one that would take a village, honestly, and we're open to doing that. I know Michael has put in our website, the link to our website. Let me see, before we close, let's see if I think we might have time for one more question.
There was no other questions in the Q&A or chat feature, but someone did reach out, and it's more, I think we've kind of touched on it. So, I mean, if anyone wants to close out on it, they said provide racial data and trends and cost analysis in this space. I think we've touched on it, but if anyone wants to make a final point on that, feel free. If not, we can move on to another question.
Yeah, I kind of wanted to, because I know there is a disparity here, especially when we're talking about the transplant list. And I think for our constituents in Alabama's 7th congressional district, we have disproportionate rates of chronic kidney disease. And oftentimes these constituents also have other diagnoses such as heart disease or diabetes, things of that nature, which can also impact criteria for transplant. And so then dialysis becomes more of a life-sustaining treatment than like a plan towards transplant even. So our office is always working to highlight these disparities. So any type of reports or anything that your organizations are doing, we will be more than willing to, at the appropriate time, highlight those on social media, add them to the Congresswoman's remarks in committee, or anything that can shed light to these disparities, because I know that's important to a lot of the work you guys do.
Thank you so much. I think that's an important point to close on. And as we close, at least for me, there are a few things that are clear. When these type of policies ignores the biology, we know patients pay the price. And I want to I can't emphasize the importance of everyone getting involved and voicing your opinion. So you could take action by commenting in these type of opportunities for RFIs to CMS. You can use NEC and NMQF's tools that we provide to voice your opinion. Also get involved. And there was an article, I know it was mentioned multiple times here. NMQF is thought about how we focus the science on how we create policy and payment systems, even technology for that matter. So there is an article that's in Health Affairs Today. The link is in the comments for patients, payment systems violating the physics of life, how ESRD bundle policies disrupt biological order in minoritized communities. I think that really spells out how we think about these issues and how it should be solved. So with that, I want to thank everyone, including my panelists, everyone who helped put this show together, and for joining us for this conversation. And thank you all for joining us, and have a nice rest of your day.
Thank you.
Thank you.
Bye, everybody.